Good afternoon. Thank you all so much for being here and spending some time um, with us talking about compensation trends and contract negotiation and what we're seeing with emergency medicine contracts this year. I just want to remind you to do your best to stick around for the entire webinar. At the end, we will provide a code where you can get a discount on Panacea Legal Services. If you're not able to stay until the end, you will get this link emailed to you later on, so you can certainly jump in and get caught back up if you have to hop off at some point. So, why are we having this conversation today? Why do these things matter? Um, More than half of physicians in the US will report experiencing burnout at some point in their careers. When we ask them why, they cite lack of autonomy, the unrealistic expectations, and the burdens that their employers put on them, and just the general workloads. Now, we're not going to be able to alleviate all of those problems, and we're not going to be able to keep all of those things from happening, but we can address quite a bit of them. We can hopefully get you a better understanding on the front end of what your expectations are going to be, and hopefully we can help mitigate some of that risk. We at Panacea are a law firm that focuses on doctor employment contracts. So we're going to help you review your contract, make sure that it protects your interests, that it helps you meet the goals that you have. We offer transparent, flat costs, so you're not going to get bills from us down the road with invoices for phone calls and emails and things like that that we've responded to. And you can come back to us for a year at no additional cost with any more questions that you have. I am a licensed attorney. I have reviewed more than 2,000 doctor contracts. That's across all specialties, all practice types, across the US. My goal is never for a doctor to sign a particular contract. My goal is always to help you make an informed decision. Sometimes that may mean realizing this isn't the job and walking away. Often it just means understanding the questions to ask and the risk that you're looking at. So today, our objectives are going to be understanding the basics, knowing what likely will be in your contract, knowing the components to look for, knowing the questions that you should and can ask and how to ask those. And then, of course, the question that everyone has, identifying red flags, how to know what's concerning, what should give you pause. So we're going to talk through those contract components. We're going to pull out a few that present the biggest potential for risk, and then we'll talk about the red flags of your contract. So we start with the contract components, the things that you're going to see in contracts. Now, everybody's agreement may look a little bit different, and you may have a 5-page contract or you may have a 40-page contract. And any of that is potentially okay. There is not a definitive answer to what exactly it needs to look like. We just need to make sure it gives us the information that we need. So starting off, of course, we want to know when your contract starts, how long it's going to last. Does it renew? Do you have to choose to renew it? How can you get out of the contract? We want to understand all of those timeline questions. We also want to know about the schedule and the location. Where are you going to work? When are you going to work? Especially in emergency medicine, where a group may have contracts with multiple facilities, and there may be many different types of shifts and obviously many different shifts to fill. We want to make sure that it's really clearly laid out what's expected of you, where you're going to be, who's going to make the determination about where you're going to work. And then if you have any additional responsibilities on top of that, if you're going to be teaching, if you're going to be supervising, if there are additional requirements there, we want to know. We also want to understand, of course, your compensation structure. And we're going to spend some time talking about the various types of structures that you're going to see. We want to know if you'll be paid a bonus. We want to know if you're getting recruitment incentives. Are they going to offer a signing bonus? Are they going to help you relocate? Your compensation needs to be clearly laid out. We want to understand the different components of compensation. We want to understand what you need to do in order to hit those metrics. We also want to know about benefits. Emergency medicine is a really interesting specialty because it's really evenly split between independent contractor and employed physician, even when you're working a full-time schedule. And we'll talk about what full-time means a little bit later on. But we want to know if benefits are offered. If they are offered, how many shifts or how many hours do you have to work in order to qualify? Um, when do those benefits start? Typically, you're not going to see PTO. You're not going to get paid unless you're there working that hour or that shift. But they may still offer CME money, though likely not CME time. You want to understand, of course, who's going to pay for malpractice insurance, who's going to pay for tail coverage. Those are significant um, costs to you and significant liability. So you want to know who will be responsible. Ideally, of course, we would love to see that the employer will be responsible. But at any rate, we want the contract to tell us. You also want to look for indemnification and financial penalties, understanding what your obligations to them are. So, when we're talking about indemnification, that means essentially whether or not they will have any responsibility um, based on your actions. We want to see that limited to situations where you're acting intentionally or negligently or criminally. We don't want to see a situation where you're indemnifying them for any and everything, meaning you're the only one with liability. Restrictive covenants are also, of course, an issue that come up really often. So there are several different types of covenants. These three are the ones that I run into most frequently and the ones that most commonly present a concern. So the first is exclusivity. That's going to look something like, hey, while you're working here, you can't go work somewhere else. Or while you're working here, you need to tell us if you go work somewhere else. Or it may just be while you're on shift for us, you can't do something else. So that what that may mean, because part of that may seem obvious, let's say that you are taking 24-hour shifts at a rural ER where volumes are pretty low. You can't be taking phone call, not taking phone calls, but taking call via phone for another entity. You can't do telehealth for someone else while you're there, right? You can't be double dipping, essentially. Um, Exclusivity that says, hey, while you're working here, you are not eligible to be working for anyone else is, in my mind, a little bit problematic, potentially. If it doesn't matter to you, then it's not. But it has the potential to be problematic with emergency medicine. Um, your schedule is, usually not going to be 8 to 5, 40 hours a week. So you're going to have some bigger chunks of time built in that you're available. And so having the flexibility to kind of do without what you want, I think is really reasonable. And again, this exclusivity applies during the term of the contract. So even in states that don't allow non-competes, you may still see an exclusivity agreement. Now, you also want to look for a non-solicitation. And what this means is, hey, you can't take people with you. Now, in emergency medicine, you're not building a patient panel. So we're not really worried about a non-solicitation relative to trying to take a patient. What we are going to focus on is taking employees or the relationship with the entity. Let's say that you're going to go work for a hospital directly. Maybe this is not an issue. If you're going to go work for a group that is employed by a hospital, the question may be, what happens if you go to another group and the hospital wants to hire that new group? Are there restrictions there? We want to make sure that it says, hey, if you, the doctor, go solicit. If you call the CMO because you know him and say, hey, I'm not with this group anymore, I'm with this other group, they're a lot better, fire those guys. Okay, sure, maybe we will say you can't do that. But if you just happen to go work for another group and the hospital just happens to hire that group, we don't want to see you restricted. And then, of course, a non-compete, the one that everybody kind of knows about and has an understanding of. These are restrictions with a geographic and a time component. It will say something like, for a year after your contract ends, you can't work within 10 miles of X. Now, again, these get tricky in emergency medicine because we're not concerned about taking patients. If you're setting up a clinic-based practice, that's really what the concern boils down to. We don't have that concern on the part of the employer with emergency medicine. So we really want to understand what does this um, what does this really try to restrict? Again, if it's talking about, hey, you can't work at this hospital because we don't want you kind of cutting us out of the deal. Here's what I mean by that. Let's say you're working for the group and the hospital pays the group, and you know that the hospital pays the group $200 an hour. But you know that the group pays the doctor $180 an hour. They may have a non-compete that says, hey, you can't come work for this hospital because they don't want you to go to the CMO and say, look, just hire me directly. I'll work for 190 an hour. You save money, I make more money. It's a deal for everybody, right? So that's where the non-compete may exist. It's actually within those particular facilities. Now, something else to watch out for is if you're working for a group who has contracts at multiple facilities and you've only ever worked at one, maybe two. We don't want the non-compete to restrict every single facility that they have. Now, taking a step back, there was some interest a couple of years ago and some movement at the Federal Trade Commission to do away with non-competes. That kind of stalled out in court, and under the previous administration, the current administration has indicated that they will not be pursuing enforcement of that rule. There has been some indication that they may be considering something that would impact non-competes for healthcare providers. That is really, really early on, and we just don't have any indication of that one way or the other, or any solid indication. So a lot of states are looking at this issue on their own and making determinations about how they want to proceed. So some states aren't doing anything, and you can have a non-compete. Some states are doing away with them altogether. Others are limiting them for doctors, limiting the amount of time, limiting the mileage. So you really want to understand what your state allows in order to understand if this is something that may apply to you. So these are the sections that, again, you'll likely see. You will want to make sure that you have an understanding of in your contract. From these, there are certainly a few that get the most attention and provide the most opportunity for problems. I'm not going to say that they certainly are problems, but they can be. Um, the first is around compensation, knowing what you're going to be paid, how you're going to be paid, what options exist there. We also want to look at risk as it relates to exit strategy. Um, so many of the questions that I get are about doctors looking to get out of a contract, wanting to understand, okay, I'm here, I don't like it, or I'm here, I'm ready to move on. I'm here, my spouse has a new job. What do I do? And then we also want to talk about the duties. And I know that this may seem really self-explanatory, but we want to know what exactly is expected of you in the job that you're being hired for. So starting with compensation, we have Dr. Jones here. He's got $250,000 salary. In his second year, his compensation has gone down. He has no idea why. He's obviously concerned about this. So the problem here is that he did not understand the compensation as it was contracted. He may have relied on what he had been told. He likely did not ask the right questions. He may not have known the right questions to ask, um, but he didn't dig into it as much as he should have. So we're going to talk through what what different structures look like. Um, Most contracts that I will see fall into these categories. Now, there may be hybrids, there may be contracts that are much more elaborate, but ultimately, I think you can kind of put them in these categories. Now, certain specialties are going to see some more frequently than others, and I'll talk about what we see in emergency medicine, um, you know, uh, more commonly. So, guarantee is the first one. And that is where we see a flat annual salary. It is not dependent upon any particular metrics. It's usually only going to be for a certain amount of time. This is not typical to see in emergency medicine. Um, it is something that is usually in more of a clinic-based position. You may see it occasionally. If you do, it's going to be for a very short window. Now, a guarantee plus production is where you have a flat salary and it may be a bit lower, but then you have the ability to earn more. So you may have a bonus based on patient encounters, based on collections, based on WRVUs. Um, you will see an element of a production bonus in some emergency medicine contracts, though not all. And again, we'll talk about a little bit more momentarily. Production only is kind of the classic eat what you kill, as it's called. And that's just going to be exactly what it sounds like. You're only paid based on what you're doing. Now, to a degree, you could say that that's a bit what emergency medicine is. The one that I think it fits in most clearly is time-based, usually. And so that's where you're going to be paid based on the number of hours, based on the shifts that you're working. Again, we see this in hospital-based practices, um, urgent care sometimes as well. So it may be this many dollars an hour, this many dollars a shift. Typically, like if we're talking about a hospitalist, you usually see that shift based. For emergency medicine, I usually see it hour based. There are different types of shifts, different lengths of shifts. For hospitalist work, we often see a night shift differential. I don't typically see that in emergency medicine. You will from time to time, but it's not as common. Now, you may also have an element of production um, here with the time-based comp. And so what that would mean is you get paid this rate, but you also get an RVU or a WRVU component of your compensation. Um, there may also be a quality component where there are particular quality metrics. Those are often done as a group. So instead of saying, hey, you as an individual have to hit these metrics, or you as an individual have to meet this many RVUs, it's going to be based on how the group performs. There can be very complex structures within groups, and then there can just be very straightforward structures. So I can't say this is exactly what you're going to see. Um, I will say this. In a situation where you are a hospital-based physician, emergency medicine being one of them, I would always advise being really mindful of how much of your compensation is tied to productivity. If you are practicing in an outpatient setting, you have some element of control over your own schedule. You could decide to have a Saturday clinic. You could stay after hours. You could take on more patients. You could open up more appointments. You know, there are a number of things. You don't really have that ability in emergency medicine. You're going to see who walks in the door. And if you are in a very, very busy um, emergency room, productivity may not be an issue. If you are in one that is less busy or less consistently busy, I would be really mindful of productivity. If you've got the time-based component and then the productivity is an added element, great. If you're in a situation where you really have to have both components pretty strong in order for your compensation to be reasonable, then I would ask questions. I would want to know what their census typically looks like, how many patients they see um, in the ER, how many doctors they typically have on staff, so how many patient encounters each doctor is having per hour, per shift. Um, I would want to know all of that. I would also look at the numbers historically, if they have them, annually, look back, not just at the last month, right? If you're joining um, right now and they're showing you from now looking back to October, yeah, those numbers may have been higher. Um, let's look at the summer numbers too, right? Let's make sure that we understand the entirety of kind of the ebb and flow of a year. So again, not saying don't allow any production component. Just really be mindful of it and make sure that you understand it. And another great question to ask is, what do your doctors typically earn? When you have somebody coming into this contract, what does their first 6 months usually look like? So these are the different types of structures that we see. And we've talked about kind of where we see emergency medicine fitting. Now, the other piece that we want to be mindful of is where there are opportunities for additional compensation. So these may not be clinic based, but these are based on additional components or the factors of where you're working. So, are you taking on any administrative roles? Are you going to be working directly with students, residents, fellows? Is there compensation for that? Um, are you going to be supervising APPs? Knowing how that's compensated, again, we may see that you're going to get a portion of APP WRVU rate. What does that look like? Understanding how that goes. And then also knowing more about your practice. Again, are you going to go work for a large hospital system that hires their own or that staffs their own emergency department? Or are you working for a group? Is the group just sort of a group of doctors that all came together in this area and they are going to staff this one facility? Or is it a larger group that maybe staffs within the city, regionally, something like that? That's going to change probably what compensation opportunities are there for you. So the next thing that we're going to talk through is the MGMA data. And that is something that comes up a lot. It is very relevant to the conversation because a lot of employers look to this data. So the Medical Group Management Association, or the MGMA, puts out a survey each year, gathering information about what doctors are paid, how they're paid, what benefits they receive, where they practice, what those settings look like, and then each year they come out with a report. And it's important to know what that report is, how to read it. And so we're just going to talk through a little bit of that, some things that I think you need to be aware of, because these numbers and these terms will likely come up. And so the first is total compensation. That is kind of the number that people are going to look to. And that's going to mean all cash compensation paid to you. It does not include valuation of benefits, does not include, any CME money, anything like that. It's only talking about money in your pocket. Now, as you see here, the MGMA data is based on the assumption that we're talking about full time. Now, you can filter it by part time, but part time can be defined a lot of different ways. Similarly, so can full time, especially in emergency medicine. I have seen 1,400 hours a year be the definition for full time in a contract. I've seen 1,800 in a year. I've seen any and all points between those. So when we're looking at this number, it's going to tell us the overall number for full time. We don't really know what was required of those doctors. And so there is, in my opinion, a little bit of limitation in the data around emergency medicine. We don't know the specifics of each position. As I said earlier, you often see a pretty even split between employed and 1099. Um, you want to see a higher rate with 1099 because you're typically not receiving benefits. So again, we don't know what uh, what status those who responded to the survey are. So the number is really still important to understand. I think it is relevant, but I think it's also important to know maybe how you differentiate. If you're looking at 18 or 1900 hours a year for full time, and your compensation is a little bit below the median, then I think that gives you a really strong footing, right? To come in and say, hey, um, I'm working maybe on the top end of what would be full time, and my compensation's a little bit lower. Now, if you're working 1,300 hours and you're above the median, I'd tell you you're in a pretty good spot. Again, all other things being equal. Now, additionally, it's going to give you the data points for WRVU production, the conversion factor, which means how many dollars per RVU. The same for patient encounters, collections, WRVU ratio to, or WRVU to encounters ratio. So for each patient encounter, how many RVUs is the median doctor, or, as a median, how many RVUs are being produced. It's all really relevant data. The data that's not there is the hourly rate. And it would be really great in your specialty if it was, but we just don't see it. Now, there are a lot of filters for this data, and you can see a lot of different um, relevant information. The data that is used, or the filter that's used for the data most frequently, is going to be the regional data. So the MGMA divides the country into 4 different regions. So you want to look at where you are. Now, there's going to be variations within those regions. If you are in a really, really, really rural, remote, isolated area, you may be above the median. If you are in the middle of a thriving medical community in a large city center, you may be below the median. Those aren't, again, not hard and fast rules, but just kind of some generalized rules of thumb. Um, we can filter the data again based on who owns the practice, how long you've been practicing, various other things. It's important to note that most of the time employers are just going to look at the regional information. Employers cannot cherry pick, meaning they can't come in and say, hey, this is the number we want to get to for emergency medicine. So let's find all the filters we need to get there. And then this is the number we want for critical care. So let's find the filters we need to get there. Right. So they just have to sort of pick the filters they're going to use and apply that. So the more you filter it based on your own set of circumstances, the less that may be something that they're willing to accept, but I think the more it should inform um, your own understanding. So we've talked about the structure. We've talked about now how to assess the structure looking at the MGMA data. So the question that I always get is, okay, should I ask for more? Right. How can I ask for more? Um, this kind of to start that part of the conversation is an understanding of emergency medicine total compensation looking at previous years MGMA. So um, this is over the last 4 years. Now, this data has done something that does happen, and I think a lot of people assume that it doesn't. It did go down from 1 year to the next. Now, as you can see, it's a fairly small dip, which is what we usually see. If there's a dip, it's typically not going to be huge. Um, and overall, over the course of the 4 years, it is an upward trend. This is looking at the number of years in practice. So understanding kind of what that growth looks like. Now, again, I think that this data is interesting, and this is something that we see in a lot of specialties, especially again, those time-based, where you're earning when you're there and producing. We see a pretty steady incline, and then in the end, um, it starts to drop down a bit. And I think that's nothing more than often an indication that doctors who have practiced that long maybe are starting to slow down a little, maybe you're working a bit fewer hours. Um, maybe they're going to a different practice setting that moves a little slower, whatever that looks like. Um, we also have this data, which is looking at guaranteed compensation for emergency medicine physicians coming right out of training. That 10,000, kind of that uh, smaller um, piece there is for relocation, and then the 25,000 is a signing bonus. Um, these numbers are not prescriptive. I'm not telling you this is exactly what you need to get. It's just more indicative of the kind of information that exists in the data and kind of what we can use as a starting point in the conversation. So again, now we know, okay, um, I've made this assessment. I know how I'm going to be paid. I know how to read the data. Now I know kind of what that data is telling us. Now can I ask for more? So I think that there are actually a lot of questions that maybe are better than can I have more? Because can I have more is very generic and is not really targeted toward an understanding of your structure. So understanding if you have any guarantee, maybe the best question is, can you extend the guarantee? You're often going to see that emergency medicine doctors are paid kind of based on the same structure. When was the last time that structure was updated? If we're looking at 10-year-old data, maybe the best way to ask for more is to ask for an update. Again, making sure the group is paid based on the same structure. If we've got quality metrics, knowing who determines those, how those are measured, how those are awarded, knowing when the structure is assessed. Call compensation is not obviously typically something that we're going to see here, though kind of being the lead physician or something like that may be something that is part of a rotation. So knowing if there's additional compensation there. Um, if you do more, do you get more? If you supervise APPs, do you get paid more? If you are willing to take a couple of weekend shifts at the critical access hospital, are those paid differently than your regular shifts? Knowing all of that is important. Knowing how and when bonuses are paid. They may not change this, but you want to know because if they're paid annually, don't walk away and leave money on the table. Um, do they offer increases at certain times, right? Do doctors make more after 3 years? Do doctors have the ability to become a partner after 2 years? Anything like that, understanding how the structure is intended to grow with you. And then just on a entry level basis, understanding what recruitment incentives are available. Are you going to qualify for any student loan forgiveness? Will they help you with your relocation? Maximizing all of those. So again, all of these questions are going to help us get to hopefully more money, but it's not just a blanket, hey, I want more. Um, so this is a conversation and a look at compensation around how to make those assessments. We're also going to talk about risks. We're going to talk about how to understand those, particularly as they relate to your exit strategy. So we have Dr. Singh here. She is employed where she trained. She is now ready to move on, and she does not really know what she needs to tell the practice where she is. So her problem here is that she is not really focused on the termination, tail coverage, or non-compete clauses. Those are going to be the areas that we need to understand as it relates to an exit strategy. So again, she may have relied on what she had seen or heard. She didn't ask the right questions, and she didn't have that strategy figured out. I strongly urge you to negotiate the exit strategy before you sign the contract. It can feel a little bit weird, but I think you're going to get the best opportunity for that negotiation when there are no emotions involved in the conversation. When you're not ready to leave, when maybe they're not sad that you're leaving, or maybe they're ready for you to leave, right? Whatever the circumstances are, this is going to be your best time. So you first want to understand if you're terminating, which of these is going to be your option. Overwhelmingly, a without cause termination is going to be what we see. And that's going to mean that nobody's really done anything wrong. Now, it can mean that you don't like them. It can mean that they're not all that nice. Um, but it means that they haven't violated the contract. They didn't quit paying you. They didn't, not give you tail insurance that they or malpractice insurance that they said they would. You're usually going to see a notice requirement here. 90 days is the most typical timeline. Anything from 60 to 120, I am comfortable with. Now, the thing that I want to really be certain of is that our time frame is mutual. I actually just reviewed a contract earlier today that said the doctor needs to give 6 month notice and the employer will give 3 month notice. Obviously, that's off balance. So you want to make sure that everybody has the same. Now, a for cause termination is going to be something that's much more rare. Um, it can carry a lot more weight and a lot more repercussions. Um, it is very rare for a doctor to have a case to terminate their contract for cause. But again, it can happen if you find yourself in that circumstance, either the one who is terminating or the one who is being terminated for cause. I would say contact an attorney. You want to be sure that you're thinking through that and that you've got solid grounds to do so. So after we determine how you can get out of the contract, of course, we want to be sure that we have talked about who's going to pay for tail coverage. This is something that needs to be laid out in the contract ahead of time. They may be providing a policy that does not require an additional tail policy. That's great. We want that in the contract. You may also see that they will tell you in the contract that they will pay for a portion of the tail dependent upon how long you've worked there. We see that a lot too. I think that's reasonable. And I think it's more reasonable if you plan to stay, that length of time. But you want to understand. If they are just adamant they're not going to do it, I would recommend talking with an insurance provider, getting some rough estimate of what that number could look like, just so you're prepared. And then let's keep it in mind. And when we are negotiating the next contract, let's see if we can get that amount in a signing bonus. Again, you want to pay attention to non-competes. You want to understand what's allowable in your state. If there is a way to limit the non-compete based on the practice type or the practice setting, that's where I've seen the most success. So it may be really difficult to come in and say, hey, I just don't like this. Now, again, I think that you've got a case for it as it relates certainly to patients with an emergency medicine contract. So what you may want to say is, hey, just I won't work for this particular location, or I won't work for any of the locations where this group, the group that you're going to work for, has a contract. Maybe you want to ask for language that says if you were to go work at the VA, they would exclude or they would exempt that work. If you were going to go do academic work, that it would be excluded. You also want to know about the repayment of incentives. If you received any of those things, the signing bonus, the relocation, there may be situations where you have to stay a certain amount of time or you would have to repay them. Know what those are going into it. If a repayment is required, and that's very common, I suggest asking for it to be prorated. So if it's a 2-year commitment, instead of saying it's all or nothing, let's forgive a portion for each month you're there. So if you leave at month 11, you're only paying back 13 months worth as opposed to the whole thing. So even within these provisions, um, making sure that you're getting the most reasonable option. So we also, of course, want to understand the other party's expectations, how those relate to your expectations, and how we can measure success. So we see Dr. Wen, who's joining a group that has Fridays off. Now, she gets her first schedule and she's working on Fridays. Now, again, this exact structure may not be what you're going to see, right? The every Friday off is not, but maybe it is a circumstance where you don't think you're going to have to work a weekend or you don't anticipate an overnight shift. Something like this that has not been explicitly discussed. Or you think all your shifts are going to be here at this one location and they assign you to multiple. The problem here is I'm relying maybe on what you've seen or heard or what you've assumed, not understanding what the contract says about those expectations and not understanding how to get at those details. These are the kind of details that I think you want to know. Um, what time is required? Again, when we talk about full time here, are we measuring that in hours and shifts? How is that scheduled? Do you have the ability to say, hey, these are the days that I'm available. These are the amount of shifts I want. Do they guarantee you any shifts? Um, you want all of that to be something that you have a lot of clarity into. Now, the exact process doesn't have to be laid out. I want the definition of full time in the contract, and I want an understanding of if that's something that they unilaterally decide or if that is based on mutual agreement. If you get to say, hey, this is what does and doesn't work for me. The same with the location. Um, if they have multiple locations, what does the contract say? Does does it allow you to be assigned to any of those? I've seen contracts that may have 10 locations listed, and the doctor will say, well, they told me it's really only going to be this one. Um, I'm not telling you that they're lying, but you also need to understand what's allowable under the contract. So, would you be okay if they sent you to any of these others? If not, then let's try to kind of rein that in a bit in the contract. Again, call is not something that is particularly of a concern here, though, again, there may be certain ways that it's applied. So, understanding if that's a requirement. And then knowing what the volume looks like. Are they adding a new provider? Is a provider leaving? What role are you filling here? And does the volume support that? These are great questions to ask about the expectations. I don't expect these questions to be answered in the contract, but I think that they're really good ways to have conversations, especially when we're talking about support staff. Um, wait times are a huge deal. Understanding um, how that impacts the overall unit. So knowing, hey, are we severely understaffed right now? Is there a tremendous amount of turnover with the nursing staff? That may not make you take the job or not take the job, but I think it's really good to know. So again, you have the understanding of kind of what the situation is. So the final thing that we'll talk through are red flags in contracts. And I know that everybody kind of wants me to have a list of, these are the words to look for. And if you see them, don't, don't sign. Unfortunately, I don't. The thing that we're really going to see as a huge red flag is a lack of transparency. Um, if the compensation structure is extremely opaque and they just tell you, hey, you'll have an hourly rate based on the location, and there will be a WRVU pool, and you'll get a proportional rate. And that's all you have. Um, I would ask a lot of questions about that. If all of the details are at their discretion and you have no more information, if you are taking on all the risk, you've got the huge non-compete. You're paying for malpractice, you're paying for tail coverage. You can't get out of the contract for 3 years. Those things are all a concern. Now, it may be that you're taking on all of that because then there's a partnership option that's really great, and that's what you're working towards. There is no contract um, that is perfect. And even if there was, what's perfect for one person is not perfect for the next. So even risk is something that really is situation specific. A non-compete for the person who wants to stay in that area forever and ever is a bigger problem than a non-compete for somebody who really doesn't care and is probably going to leave when his or her partner finishes residency in a couple of years. So that's why there's really not, like I said, these are the problems, but an imbalance of risk and a lack of transparency is really problematic. And that's where I would tell you to be cautious in moving forward. So, as I said, I really appreciate the opportunity to talk with all of you today. You can see on your screen that there is a 20% off discount being offered today. The promo code for that is EMCOMP20. When you go to our website to sign up for a review, you can enter that code in and get 20% off. My email address and our website are on the screen here. My name is Jillian, and I would love to answer any questions that you have. Please feel free to reach out to me and let me know if there is anything you need. Thank you so much.